So, very good morning to all of you. Today's our topic is very important topic from exam point of view, whether theory or practical. Most of the time you are getting nowadays GI cases or respiratory cases. So, among GI, cirrhosis of liver is most common presentation of the people in GI cases which have positive finding. So most the chances are that 30-40% you may get a patient of cirrhosis during your final examination. So cirrhosis of liver will move. This is a diffuse process characterized by fibrosis and conversion of the normal architecture of liver to structurally abnormal nodule. So cirrhosis denotes injury to the liver, and hepatocytes respond by making fibrosis, more fibrosis in the liver. So architecturally the hepatocyte and their normal architecture is disturbed, that is destroyed, and liver try to regenerate by itself by way of fibrosis. So and there is formation of abnormal nodules. It can be the final stage of any chronic liver disease. So whether it is infective or due to congestive, or if it is due to toxic effect of some drug or metabolic diseases, everything, even by malignancy, malignant patients, say CA breast or any CA lung, there are hepatic mets. Ultimately they go into cirrhosis or portal hypertension and they die of their complication. So these regenerative nodules lack the normal lobular organization and are surrounded by the fibrous tissue. And this process, when we say fibrosis, any part, any vital organ, it denotes that the injury was irreversible now. So once patient develops cirrhosis, chances are nil of recovery. Patient may remain static or may deteriorate. So it is irreversible process, and classically it may be either compensated or decompensated. So people are coming for having fun here. So it can be histologically, it can be compensated or decompensated. So histologically you can classify cirrhosis into two, micronodular and macronodular. Fine nodular or micronodular, usually it is in alcoholic cirrhosis and also termed as Lennox cirrhosis. Macronodular cirrhosis is large nodule of varying size. So size is different of each nodule. So varying size, maybe 2-3 millimeter in size, one nodule, and another maybe 12 to 15 millimeter in size. So rough surface as such, rough and varying size nodules are there. So it's not symmetrical nodules. So it is being termed as macronodular cirrhosis, while fine nodular will be around 1 millimeter or less than that. Large nodules of various sizes, areas of previous collapse of the liver architecture are evidenced by large fibrous scars. So nodules are due to scars development, fibrosis development, and it will be of different. Now you can see the gross appearance of the liver, say normal liver, micronodular cirrhosis, and macronodular. Yes, you can please. You can close the door now. Causes of cirrhosis. So most common causes which lead to cirrhosis we find in clinical practice in our wards, either hepatitis C, hepatitis B, alcoholic liver disease, and non-alcoholic fatty liver disease. So alcoholic liver disease is most common presentation in our wards. Most of the people are alcohol addict, and when their liver get damaged more than 80%, they go into cirrhosis, and they come with the decompensation and they get admit here. So alcoholic liver disease is the most common, and another infections, another nowadays non-alcoholic fatty liver. Previously everybody was telling this non-alcoholic fatty liver or steatohepatitis is nothing. Please leave, please. Close the door. So it is of no significance. It is benign only. But nowadays we are finding many people who have never touched the alcohol. All their reports only showing fatty liver disease of non-alcoholic origin. So non-alcoholic fatty liver disease. They are going into cirrhosis. Their liver start contracting, there are nodule formation, and they go into decompensatory phase. Even they are developing frank cirrhosis, frank ascites, and later on even they develop carcinoma also. So it is not a benign disease, and you must take care of the disease. So other causes of cirrhosis, apart from this is total less than 2% of all cases. So most of the cases will be alcoholic, hepatitis C, B, or non-alcoholic fatty liver disease. So other causes are cholestatic and autoimmune liver diseases, or intrahepatic and extrahepatic biliary obstruction, metabolic disorders like hemochromatosis and Wilson's disease, hepatic venous outflow obstruction. So Budd-Chiari syndrome, veno-occlusive disease, drugs or toxins. So particularly paracetamol poisoning very common in foreign countries because people are alcoholic. Now from bank entry. Is there a way from bathroom to here? From backside? So drugs and toxins. Particularly alcoholic hepatitis patients should not be given high doses of paracetamol. They will go immediately into decompensation. They will go into hepatic failure. And another is Indian childhood cirrhosis, as commonly termed as ICC, very common in pediatric age group, not in adults. So pathophysiology. So following injury, liver injury, the activated stellate cells in the pericynocidal spaces are activated by cytokines, which are produced by Kupffer cells and hepatocytes. So when the hepatocytes and Kupffer cells get damaged or got injured, then they will produce cytokine and they will stimulate the stellate cells in the pericynocidal spaces. So they will start making fibrosis. So the stellate cells get transformed into the myofibroblast, which is capable of producing collagen, pro-inflammatory cytokines and mediators that promote hepatocyte damage and tissue fibrosis. Over the years, progressive fibrosis and widespread hepatocyte loss lead to the distortion of the normal liver architecture that disrupt the hepatic vasculature. So firstly, their hepatic architecture, so mainly the hepatocytes and the Kupffer cells and this one stellate cell, all these are activated and they destroy each other, and also they disrupt the hepatic vasculature. That's why there is portostemic shunt is there. So causing portostemic shunts, these changes are usually affect the whole liver. So first the liver architecture and then vessel involvement. So systemic clinical manifestation of liver cirrhosis, you can see the signs and symptoms may be neurological, GI, reproductive, skin, hematological, metabolic and cardiovascular. So neurologically what is most dreaded is hepatic encephalopathy, peripheral neuropathy, asterixis, that is flapping tremors. So patient may present with flapping tremors, and this is given in your book also. So GI, there may be anorexia and dyspepsia, nausea, vomiting, change in bowel habits, dull abdominal pain, fetor hepaticus, esophageal and gastric varices, hematemesis, hemorrhoids, congestive gastropathies. In reproductive, what we look for in chronic cirrhotic patients, they will present with the male particularly with the gynecomastia, testicular atrophy, and female amenorrhea. Skin, there may be jaundice, spider angioma, palmar erythema, and purpura petechiae and caput medusae. Hematologically, thrombocytopenia is most common. It is due to splenomegaly and splenic sequestration of the thrombocytes, platelets. And another is anemia, as leukopenia also may be present. So, patient may present with anemia, low hemoglobin as well as low CBC counts. Coagulation disorders and splenomegaly also of the in the hematological disturbances. So metabolic, there may be hypoalbuminemia, which is more prominent. Patient come with the swelling over the feet, and then it progresses towards the whole body. And also there will be hyponatremia as well as hypokalemia. Cardiovascularly, fluid overload is there. So fluid retention is there, peripheral edema and ascites. So 1/3 of patients of cirrhosis usually are asymptomatic. They are not decompensated, so still they don't have any sign, and they will come to you without any symptom. Fatigue may be the first symptom. Disturbed sleep cycle and muscle cramps and weight loss are common. So patient due to anorexia, they will develop the malnourishment and there will be protein losses. Anorexia is usually present and may be extreme. There may be abdominal pain and related to either hepatic enlargement and stretching of the Glissen's capsule as well as presence of ascites. So clinically you may find jaundice. So first you see the sclera, it is yellowish discoloration, better seen in the sunlight. In 70% of cases, liver may be enlarged. That is early stage, so liver may be enlarged. But as the cirrhosis progresses, more fibrosis, more contraction in the size, so liver will start contracting and it will be smaller in size. And there may be presence of nodular edge. As you say, this is either micronodular or macronodular. So if macronodular, you may feel nodular edges. And in few of the patient, left lobe enlargement is more prominent rather than the right liver enlargement. Splenomegaly is present in up to 50% of patients. So half of the patient, 1/3 to half of the patient may show splenomegaly, enlarged spleen. This is due to back pressure from the portal vein. So there is back pressure in the portal vein. Portal hypertension is there. It causes increase in the venous blood pooling in the spleen. So it will start enlarging. So splenomegaly is there. Usually it is mild only. Skin may show spider telangiectasia in the upper half of the body. Palmar erythema may be present. Dupuytren contracture may be present, and there may be vitamin deficiency because liver also participate in formation of vitamin D from D1 to D2. So there is vitamin D deficiency also. There may be petechial and hemorrhage, and there may be ecchymosis. Menstrual abnormality, as I told you, among the hormonal disturbances. So erectile dysfunction, loss of pubic and axillary hair, breast atrophy is there in the female, and gynecomastia and testicular atrophy in male. So this is a classical picture of Palmar erythema. And spider angiomata you can find in Indian patients also very well. It is usually around umbilicus. So lab finding, you may find either no change in the laboratory finding at early stages, but later on you may find anemia. There may be thrombocytopenia, which is the most common cytopenia in the cirrhotic patient. It is secondary to alcoholic marrow suppression, because most of the cases are due to alcohol-induced liver injury. So sepsis, also folate deficiency, and splenic sequestration. All these causes lead to the thrombocytopenia. There may be PT INR is deranged, and increase in the AST, that is SGOT, as compared to, because liver patient they'll show more of the SGOT. SGOT is more than the SGPT in liver patients or this alcoholic patients, alcoholic cirrhosis. So AST level is high, alkaline phosphatase level is high, and increase in bilirubin, serum albumin decreases, and increase in the gamma globulin level. Vitamin D deficiency. So USG is prime in diagnosing cirrhosis of liver. So it will show you the liver size, and it will detect the ascites. Hepatic nodules may be seen if it is very large, macronodular, and sometime you may find hepatic carcinoma also. So Doppler study may establish the patency of the splenic vein, portal vein, and lymphatic vein. So all these are more common. Thrombosis is more common in these patients because of affection of the fibrinolytic factors in their this upper GI endoscopy. Sometimes patient we suspect cirrhosis, but this is not showing anything USG. Then we will go for upper GI endoscopy. If there is esophageal varices, that means there is portal hypertension is present there. Sometimes we see the bleeding varices there. So whereas hepatic vein pressure also you can measure. Liver biopsy is the final to any hepatic pathology. So, but usually it is very rarely done, because all other models point out to some kind of pathology, and our work is done. So usually we don't go for the hepatic biopsy, but if diagnosis is not settled, still etiology is not certain, then we can go for the liver biopsy. So what cirrhosis do? Either it will cause liver insufficiency, or it will cause portal hypertension, or both. So if portal hypertension, it will cause varices formation, esophageal, and there will be hemorrhage, or it can cause ascites because portal pressure is increased, so there is more lymph formation, and it will collect in the intraperitoneal region, so it will lead to ascites formation, or it may cause encephalopathy. So also liver insufficiency, it can cause jaundice, and if it is severe, it will lead to encephalopathy. If ascites, you have to look for the SBP, that is spontaneous bacterial peritonitis, or hepatorenal syndrome. So complication of cirrhosis we already saw, it can lead to portal hypertension, development of ascites, or hepatorenal syndrome, and hepatic encephalopathy. Other minor very less commonly found, hepatopulmonary syndrome, portopulmonary hypertension, malnutrition, coagulopathy very common, bone diseases because of vitamin D deficiency, hematological abnormality very commonly found, particularly thrombocytopenia. Anemia is quite common, sometimes neutropenia you may also find, or hemolysis may be there. So what happens when chronic liver disease? It lead to compensated cirrhosis, and when the complication develops like esophageal varices, ascites, encephalopathy, or jaundice, that means patient has gone into decompensated stage. Compensated cirrhosis may develop to go into decompensated cirrhosis. Sometimes without going into decompensation, patient may go into HCC, that is hepatocellular carcinoma. So it is not necessary that first there will be decompensation and then there will be development of hepatocellular carcinoma. Even without decompensation, patient will go into hepatocellular carcinoma. Final stage is death. So clinical feature of hepatocellular failure, we all know, we look for jaundice, and if pedal edema, that gives rise to us a clue that patient may be suffering from the cirrhosis. Other may be fetor hepaticus, parotid enlargement, spider nevi, bruises, purpura, loss of axillary and pubic hairs, breast atrophy in female, and gynecomastia in male, Dupuytren contracture, asterixis, white nails, and clubbing. So all these are clinical features. So hepatic encephalopathy will go hurriedly. This it is a brain dysfunction caused by liver insufficiency. So any encephalopathy caused by liver disease, it is termed as hepatic encephalopathy, and this is due to portosystemic shunting or due to liver insufficiency or due to both. So ammonia plays a key role in pathogenesis. So we say it is hyperammonia condition. When ammonia levels are high, brain get disturbed. Why it is disturbed? Large amount of ammonia in the brain damage the astrocytes, which are again a background material, that is fibrous tissue-like thing. So astrocytes are damaged and lead to structural changes characteristic of hepatic encephalopathy, and patient may present Alzheimer type 2 astrocytosis. Ammonia results in stimulation of neurosteroid production. So more production of GABA, that is gamma aminobutyric acid. So it causes some sedation in the patients, mild. So we'll see later. So which results in cortical depression and hepatic encephalopathy. Other toxins are also involved in hepatic encephalopathy, particularly manganese, which also accumulate in the brain, particularly in the globus pallidus, where they lead to impaired motor function. Other still not discovered toxins may be also in the etiology of the hepatic encephalopathy. So patient with covert hepatic encephalopathy have no recognizable clinical symptom but may demonstrate mild cognitive affection, psychomotor affection and attention deficit, and these may lead to increased RTA, road traffic accidents. So in these patients we have to be careful. So precipitating factor, as all you know, it is due to constipation. Most commonly we have heard about constipation. If cirrhotic patient not gone motion, it gives us irritation as well as anxiety, because the patient may go into hepatic encephalopathy. 3 दिन तक motion नहीं गया, definitely he will go into hepatic encephalopathy. So he should have frequent bowel motion. So high protein diet should be avoided. GI bleeding, esophageal varices, they have already, if large amount of blood is passed, this all with is proteinaceous material, it will be reabsorbed from the GI and it will give rise to more ammonia level and urea level. They all will cause hepatic encephalopathy. Also infections, so particularly SBP, spontaneous bacterial peritonitis, this may lead to precipitate hepatic encephalopathy. So any excessive diuretic, if you are doing intervention, say ascitic tapping, it may lead to hepatic encephalopathy. So we have to be very cautious in such patients. Particularly we should try it for after giving albumin infusion simultaneously. So albumin infusion to be given, albumin should be replaced side by side. So we always practice usually with hepatic albumin infusion, and then we'll do ascitic tapping. So any surgical portosystemic shunts tips, they also may be the precipitating factor. So constipation, bleeding, infection, diuretic, ascitic tapping and surgical shunts. Sedatives and hypnotics, because most of the sedative drugs are metabolized by liver. So if we are giving sedative in these patients, they may go into hepatic encephalopathy because the level will be persistent. They will not be metabolized by the liver. So wide spectrum of neurological and psychiatric abnormalities are ranging from subclinical alteration to coma. So grade 1, 2, 3, 4 hepatic encephalopathy, you should remember. You can remember by reverse method also. Say grade 4 is coma, grade 3 is moderate disorientation, grade 2 is mild disorientation, grade 1 is alteration in consciousness and behavioral pattern and sleep-wake cycle. So, and forgetfulness. On physical examination, we always, with these patients, when we go for rounds, we'll ask the patient to outstretch his hands and we'll look for the flapping tremors. We'll ask about whether he has passed motion or not. So these two things we are seeing on the rounds. So to save the patient, we have to look for these signs. So asterixis has to be looked for, and sometimes there will be fetor hepaticus. In these patients, because of mercaptans, there is sweet smell from the patient's breath. Bedside test for hepatic encephalopathy, this is for, just to mention, this is for usually PG people. So arms extended, we have to ask for dorsiflexion. Ask him to keep like this. Go on talking to him anything. Ask him to keep the hand fully dorsiflex and watch for whether he is doing like this. So there will be momentarily disturbance in the posture of the dorsiflexion. So it will be again palmar flexion. So this is flapping tremor or asterixis. Bedside tests. So these are the tests for usually for PGs only. Hepatic encephalopathy management, as I told you, first thing ask for the motion he has passed or not. So lactulose to be given daily in this patient, so that it passed at least 2 to 3 loose motions daily he is passing. This will safeguard the patient from development of hepatic encephalopathy. Even treatment is same only. So lactulose to be given at least 3 to 4 loose motion daily he should pass. Once he passes motion, patient will revert from the hepatic encephalopathy within few hours. So lactulose 15 to 30 ml 3 to 4 times daily, gradually increase until the bowels are moving twice daily or 3-4 times daily. It produces an osmotic laxative effect and reduce the pH of the colon. So it will hamper the colonic ammonia absorption. So when pH is reduced, that means more acidic pH in the colon. So less ammonia will be absorbed. Opioids are rifaximin. When patient is not tolerating lactulose due to some other reason, he is not responding, then we will go for rifaximin. This is a new drug which is non-absorbed antibiotic, 400 to 550 milligram TDS. So it will reduce the bacterial content of the bowel, shown to be effective. So sedative to be avoided. The only sedative, oxazepam, which is nowadays not available. From last 20-30 years, this sedative is not available in our country. Rather, we are giving haloperidol, that is Serenase. So protein should not be given in excess amount, should be only 1 gram per kg. So up to 60 to 80 milligram per day. So, but it should be 1 gram per kg only. Another drug is hepamers or L-ornithine L-aspartate, which act through the mechanism of substrate activation. So to detoxify the ammonia, it will detoxify the ammonia. Once we see the ammonia level, if it is high, then we'll prescribe hepamers. And the dose usually IV, sometimes sachet orally we can give. Patient is okay, then we'll go for the sachet. If he is in deep coma, then we'll go for the IV infusion. So it is about 5 gram of 1 ampule. 6 ampules are dissolved. So 30 gram total in the 500 ml of dextrose, and to be given over 5 to 6 hours or 8-12 hours, and it is to be repeated for 5 days. And definite answer is the liver transplantation. So what are the most commonly used scoring system in the cirrhosis? So you should know at least what does this one is very common, child PERC score system or child Turcotte PERC scoring. Range is 5 to 15. So 5 parameters are looked for. One is ascites is present or not, mild, moderate, severe, hepatic encephalopathy, grade 0, grade 1, 2, grade 4, 3, 4, or bilirubin level less than 2 or more than 3, albumin more than 3.5, that is normal, or it is in between up to 2.8 or less than 2.8. So PTINR, it should be less than 1.7. If it is up to 2.3, grade 2, and if more than 6, 2.3, it is grade 3, 3 scoring. So we have to add up all these, ascites and hepatic encephalopathy, and laboratory bilirubin, albumin, and PTINR. So MELD score also model of end stage liver disease. Just you should know there is some scoring, MELD scoring, but this will take in account the usually creatinine and bilirubin and PTINR. So bilirubin, PTINR, and creatinine. Another topic is portal hypertension. We already discussed. So it is result from both an increase in the resistance to portal flow or increase in the portal venous flow. So normal hepatic venous pressure gradient is usually 5 to 6 millimeter between the wedged hepatic venous pressure and the free hepatic venous pressure. Clinically significant hypertension or portal hypertension is present when gradient is more than 10, and complication will occur when it is more than 12. So portal hypertension again can be classified according to the level of the affection. So pre-hepatic, hepatic, or post-hepatic. Even in hepatic, pre-sinusoidal, sinusoidal, and post-sinusoidal. So in sinusoidal causes cirrhosis. In pre-hepatic, usually venous system, portal vein thrombosis, splenic vein thrombosis. Post-hepatic, Budd-Chiari syndrome, like superior hepatic. I'll show the picture. So cardiac causes, restricted cardiomyopathy, constrictive pericarditis, or severe congestive heart failure. Even cardiac causes may lead to post-hepatic type of portal hypertension. So you can see the normal pic on the normal liver on the left side, circulation, hepatic sinusoids normally working, and above is the hepatic vein, below is the portal vein, which is formed by the splenic vein and superior and inferior mesenteric vein. So portal pressure, sinusoidal pressure usually 3 to 5 millimeter, but when liver is cirrhotic, there is compression of the sinusoidal vessels, and there is increase in the portal vein size. You can see portal vein is dilated now, splenic vein is dilated, spleen has become enlarged, and there is development of collateral at the upper border of the stomach, at the lower end of the esophagus, and periumbilical region. So all these will explain you. So portal hypertension, splenomegaly is the cardinal sign. I told you. Spleen will enlarge due to congestive back pressure. Collateral vessel will be developed around the umbilicus caput medusae. Sometimes they are so enlarged that venosum you may have heard here, and this has been given sign of Cavalier-Baumgarten syndrome. Fetor hepaticus is present in these patients. Most important is variceal bleeding when gradient is more than 10 to 12 millimeter of mercury, and further dilatation when there is variceal development, further dilatation, more pressure, back pressure. This will lead to rupture and variceal bleeding, and it will manifest with hematemesis and later on melena. So we have to ask about if patient is having any black stool, or he is giving history of vomiting with blood, or totally pure blood vomitus. So variceal bleeding. So how to treat? So beta blocker therapy. Beta blockers will reduce the portal vein pressure. So non-specific beta blockers, generalized one, non-selective one. So propranolol is the ideal one. So Inderol with the dose of 10 milligram to 40 milligram, 80 milligram to 1. How much? Because these patients usually have low blood pressure also. So we are scared of giving higher doses in our patients. So in particular Indian context, we are giving only 10 to 20 milligram per day, and will increase up to 40 milligram, sometimes 40 milligram BD. So up to 80 milligram we are going. But in European countries and US they are giving up to 160 milligram of propranolol. Also, if patient is bleeding, then prophylactic is broad spectrum antibiotics, and to stop bleeding, we may use terlipressin or bending or sclerotherapy or balloon tamponade or TIPS is surgery, the shunt procedure. So emergency management of bleeding, if there is massive bleeding, we have to replace the fluid, we have to give blood also, and we have to give vasopressors, terlipressin, which will reduce the pressure in the esophageal vessels. Prophylactic antibiotic you have to give. Endoscopy you have to do in emergency to stop the bleeding. You can go for the band ligation. So bleeders you have to stop. Proton pump inhibitors to reduce the pH. This one increase the pH. So more toward alkaline side. So there is not much bleeding. Enema to be given, lactulose enema or phosphate enema to be given. So in case how we say suspected variceal hemorrhage, start IV terlipressin and give antibiotics, upper GI endoscopy. If varix present, you go for the variceal bending or ligation, and sclerotherapy, that is glue therapy, glue injections we give. If hemostasis or bleeding is controlled, we'll continue terlipressin for 3 days, and then we'll call the patient again after 2 to 3 months, 6 months to see for the variceal size and ligation them. If there is no it is not controlled, then we go for the balloon tamponade or emergency tip surgery. So this is congestive portal hypertensive gastropathy due to back pressure. Not only esophageal varices, but also in the stomach, the vessels are prominent. So there is hexagonal type of appearance of the mucosa. चकत्ते hexagonal type हो जाते हैं, तो gastropathy we term them. Cardiopulmonary complication may occur, hepatopulmonary syndrome, ascites. This is most common complication. So increased abdominal girth and increased weight. On examination, we find free fluid in the abdomen and shifting dullness is present. Usually, abdomen is non-tender only. Mild pain, abdomen may be there due to distension, but usually no tenderness is there. Cirrhosis lead to sinusoidal hypertension and will cause vasodilatation of the splenic arterial system. So there is more production of splenic lymph, and it will collect as a ascites. Also, the pressure in other vessels will decrease. So, the renin-angiotensin system will be activated. It will sense that low volume is there inside the vessels. So, it will start conserving the sodium, and there is retention of sodium and fluid also. So, ascites pathophysiology is this one. First is sinusoidal hypertension, and second is renin-angiotensin system sense that there is less pressure in the vessels. Also there is hypoalbuminemia, so oncotic pressure is less, and the blood from the vessels, it goes out of the this splenic vessels, and they will collect as a lymph. So cirrhosis will lead to portal hypertension and splenic vasodilation. There is increase in the splenic pressure and lymph formation. Ascites formation is there, and arterial underfilling, as I told you, activate the vasoconstrictor and ADH hormone, and it will lead to sodium retention. So ascites management, how to manage the ascites? First is tapping, second is giving diuretics, third is replace albumin. So we have to see for the SAG, that is serum ascites albumin gradient. Serum ascites albumin gradient. So serum ascites minus serum albumin minus ascites albumin. This is the gradient. What is the difference? Usually when transudate, the cirrhosis is usually transudate ascites. So albumin level in the blood is more, serum is more rather than the ascitic fluid. So we have to decrease the sodium intake, fluid intake is to be restricted in these patients. IV albumin is the definite therapy, and spironolactone, furosemide, diuretics you can give. and by these you can decrease the fluid collection inside the body. Also, we can give concomitant IV albumin as well as ascites drainage. And definite treatment is, of course, TIPS therapy or liver transplantation. So refractory ascites, same thing only. SBP, spontaneous bacterial peritonitis. Any patient with ascites, he is coming complaining of pain abdomen, there is history of fever, there is tenderness, rebounding tenderness. In the absence of perforation or any other abdominal inflammatory focus, then we label it as a SBP, spontaneous bacterial peritonitis. So there is migration of bacteria from the intestinal lumen into the mesenteric lymph node and the peritoneal cavity, and they will lead to infection of the peritoneum. There is, because of impaired immune defenses, risk factors, PPI, they also say also PPI is one of the factors. Variceal bleeding, as I told you, this is very common precipitating factor for SBP. Infections, usually monobacterial infection, they are the cause of the this one SBP development. So any patient of ascites developing abdominal pain, tenderness and fever, and they show bowel sound absent, that means SBP is there. And on cell count, you will see up to 500 cells are there, and polymorphs are 250. Polymorph predominant fluid is there, that means it is SBP. Usually it is due to E. coli and Streptococcus, and broad spectrum antibiotics we give. Usually cefotaxime is preferred in these patients, and prophylactically we can give ciproflox or norfloxacin to prevent recurrent development of SBP. So this is all about cirrhosis, compensated or decompensated, how you have to monitor it. I told you just now. This is one just to show you. Previously this tube is being used by gastroenterologists. Blackmore, Sangstein Blackmore tube, which is 4 lumen tube. So there is 2 balloons and 2 catheters for aspiration of the gastric and esophageal contents. So by this we will fix the balloon in the stomach, and esophageal balloon is inflated, which will compress the esophageal varices. So for emergent variceal bleeding, pressure we will apply, and we will try to stop the bleeding from the esophageal varices. So this is all. You can see the varix bleeding like this. In the last there is banding is, you can see white color banding is there, and this is all TIPS. You can go for TIPS, that is transjugular intrahepatic portostomach shunt. You can read in your book. So portal vein as well as this shunt is to be placed in between portal vein and hepatic vein. Hepatorenal syndrome, when in absence of kidney disease, urine formation is less. In presence of cirrhosis, a patient's urine formation is less, there is no history of shock, and there is no nephrotoxic drug given, there is no structural kidney disease present, and failure of kidney function to improve when we stop the diuretic and we are giving albumin. Even then, patient not recovering after 48 hours, we label it as a hepatorenal syndrome. Again, treatment of choice is albumin replacement and terlipressin IV. Prognosis is more favorable when you can reverse the or correct the underlying causes. So all these will lead to acute decompensation. So survival rate is poorer when scoring high. I think this is enough for today.